Hi, I'm Dr. Richard Jermyn, Dean of the Rowan-Virtua School of Osteopathic Medicine. Welcome to Dialogue with the Dean, our Vodcast series where we're highlighting thought leaders who are advancing the mission of our medical school. Our mission is to foster innovation, excellence in education, and transformative healthcare practices. Today, I'd like to welcome Terri Drye, who is Assistant Vice President and Chief Human Resource Officer for Rowan University and Chief Administrative Officer for the newly affiliated Rowan University and Virtua Health Alignment. Terri has administrative oversight for the Rowan-Virtua School of Osteopathic Medicine, including Rowan Medicine, the Salva School of Nursing and School of Translational Medicine and Biomedical Engineering. She's a fellow of the American College of Healthcare Executives and a board member for the MGMA New Jersey chapter. Terri, welcome. I'm so happy to have you here today.
Excited to be here with you, Rich.
Now, let me just start out. We talk a lot, and I think people always think of you as in your HR role.
Right.
But your heart has always been in the medicine role. Can you just tell us all about how that developed and what brings you here today?
Sure. Well, my career started, I'm a recovering accountant that really fell into human resources by accident through the payroll side of the house. And in 2003, I went from higher education in HR to healthcare and really found a passion there. Because of the business background in accounting, they started to assign me other responsibilities of oversight for security or radiology or environmental service. And that really grew where my career went from not just human resources, but to really the chief administrative officer, the oversight for clinical and non-clinical departments. And what it did was really provide an opportunity for me to understand the full 360 of what impact HR policies have, but also what impact it has on the service line, on the healthcare delivery, and watching healthcare evolve. For decades, when the American College of Healthcare Executives did a survey every year, and they asked CEOs one question, which was, what keeps you up at night? For decades, what kept them up at night varied between finances and quality. In 2017, for the first time, there was a drastic change, and the number one issue keeping CEOs awake at night is workforce shortages and how we deal with the human factor in healthcare.
Yeah. Well, let's talk a little bit about that. I've heard you talk about elevating the human side of healthcare. What do you mean by that?
Well, we used to look at access and affordability and quality, but we really have to look at patient experience, physician engagement, employee engagement, because every hospital has a CT and an MRI and a Da Vinci robot, but the only thing that really differentiates it is the people. Yeah. And so it's really critical, and if we already have a workforce shortage, we have to be able to retain and grow our own people. And if we're not doing that, then we're going to struggle. And when I came into healthcare, the margin was 4%. Now, prior to COVID, it was down to about 3%. Now it's 1% to 2% post-COVID. So we have to look at how do we keep those resources? How do we provide that quality care with increased cost, supply chain issues, needs for technology, and that all has to circle around the people.
Putting the patient in the center.
Right.
So you talk about this three-legged stool, right, of physician engagement, employee engagement, and patient experience.
Yeah.
So tell me, how do they come together?
Yeah. Well, if you're an employee and you're not happy to be there, if you're not engaged, the patient is going to sense that. You're not going to have that same level of patient experience for that person. Our employees have to be tied to the commitment and the passion and the patient-centeredness of the organization. They really have to feel that they are part of the organization. And I think one of the things we do well in healthcare is make everyone a part of the team. To exemplify through a story, at a level 1 trauma center in Northern Virginia, we had an amazing program that we recognized our employees, and we did it in a really great time. We did it before every senior leadership meeting. And we recognized, whether it was from patient comments, whether it was from nominations, people who had provided exceptional care. And the fact that we did it before the senior leadership meeting really put in perspective why we were there and what was important as we move forward. But we had a terrible event in that area where 3 police officers were shot. One unfortunately passed away on the scene, 2 came to our hospital. One was not critical and was taken care of easily. The other coded several times on the table, but we saved him. We, of course, had many, letters from the family, from the community, and we recognized that team. We didn't recognize just the trauma surgeon. We recognized every single person, from the trauma surgeon to the guest service person, because every one of them contributed to that patient experience. And that's what in healthcare everyone needs to feel, that they're part of that experience. Even the HR recruiter is contributing to saving lives by making sure that there are nurses and lab techs where they need to be to save patients.
So I love that example, because it kind of leads into my next question for you. And that is, you learn a lot about physician burnout, but even team burnout.
Right.
You mentioned it's really the whole team.
Yeah.
What are some ideas or thoughts in our new relationship with our hospital system and our ambulatory? How do we really prevent? What are some tools that we could have, ideas in preventing burnout?
Yeah, and I think I would look at it in 2 steps. One being the physician burnout, of really looking that we continue to ask our physicians to do more and more. And physicians have gone into medicine because they want to provide patient care, not because they want to document an electronic health record. And the more we, as great as that is, the more we add to that, the more regulations we add, the more administrative responsibilities we add, the less time our doctors have to provide care. The more time that they're spending what we refer to as pajama time, where it's anywhere from 10 to 15 or 20 hours a week are spent at night at home trying to catch up on the electronic medical record and doing work that wasn't able to be done, and we're burning our physicians out. We really have to look at what we're doing with that, how we're looking at AI.
Yep.
Our partner Virtua is certainly looking and beta testing on what that looks like. We have to look at how we deal with the amount of regulation and administrative time, and make sure that we're respecting that time, making sure we're also training and providing for our physicians. The Joint Commission actually did a study indicating that 72% of sentinel events are a result of physician orientation, competency, and credentialing. And that's all a matter of providing the resources to our physicians that they need to provide great patient care.
So, we have medical students and residents and trainees listening to us today. In your experience, in my experience, a lot of times if you're a good doctor and you provide good care, then all of a sudden you're a physician leader. And that doesn't always work, right?
No.
So how do we really develop leadership and physician leaders for the future?
Well, I think, we'll talk about physicians, but I know, years ago the joke was that the only difference between being a charge nurse and the nurse director was 48 hours over the weekend. And then suddenly we expected that person to be able to do performance evaluations and budgeting and productivity and everything simply because we gave them a title. And I think with physicians, and I think what was most interesting was a book that was written by a former head of the American Osteopathic Association. And it was really unique to me, as often as I've worked with physicians, it never really occurred to me that the training is very different. You don't go into the examining room and say, so tell me your thoughts about what might be wrong with you. We train physicians to come in and diagnose and give a direction, But then we expect that they're going to go into a meeting room and say, well, I'm going to be collaborative, and what are your thoughts? But I think we have to start with young physicians. Leadership doesn't occur overnight. It's really looking at how we build in learning and development institutes. As we've talked, that we've, here at Rowan Medicine, we've had a number of doctors come through our university program, but would really love to start creating a much more specialized physician leadership program. Participated in one several years ago at that same trauma center, and it was a 9-month program. And it was really looking to say, here's the basic skills, but also then how can we start getting you on the right committees? How can we start getting you the skills and experience so that you're able to do it?
So I love that, and I would just encourage our medical students out there to really reach out to us, and say, hey, I'm interested in being a physician leader, and you know who you are, and so, and I actually think we should have, rotations on this, and we're discussing that. And even fellowships in the future on how to develop leadership for people that really just want to go into that and use that skill set. Let's circle back around patient care a little bit. And you had mentioned before about teams, and we spent a lot of time talking about physicians, but how do we engage our employees?
Right. Yeah, and I think from our employee perspective, I think one of the most important things, as I mentioned, is truly engaging them as a part of the team and a part of the mission. Because this is an area that the people have gone into because they want to help people. So we have to make sure that we give them that opportunity. We have to treat them also with respect. I remember we've moved a long way in 20 years that I've been in healthcare. I remember in 2004, you were given a day shift or a night shift, and it rotated, and you had mandatory overtime, and all of those things, thank heavens, have ended. But we have to build in that respect, that trust. We have to make sure that senior leadership is modeling it. When we first started years ago with patient experience, senior leaders went running around doing rounding, and we would all show up in our suits and didn't know why everyone scurried and every nurse was suddenly in a patient room because they didn't know why we were there and what we were doing. So it really has to be genuine. I know of CEOs who block off a day a week and come in scrubs so that they can be on the floor, they can help assist with moving patients, they're really there and engaged with the employees.
I think it's important to know how you collect your data. I think it's critical. I'm going to give you an example in some of the work that I do. Years ago, not too long ago, literally a few years ago, you would get patient surveys, and one of which was pain surveys, right? And you probably know where I'm going with this. So what happened was patients would come in and they would ask, was your pain treated adequately, which is an important question. But what happened was if they weren't given opioid medications, people that were seeking opioids, they would get dinged very badly. And then the physicians were told, you have to do this to increase. And then what happened was that really fostered the opioid crisis. So I think it's a challenge to all of us to make sure that when we collect the data, that we know exactly what it is and what it's just not, are you happy, but what are you really measuring that is meaningful, right? And what are we doing right and what we're doing wrong, not just to check a box.
Right. And I think comments are very important in the surveys. They really help. And a lot of the surveys are driven by, would you recommend?
Right.
And that's really important. You're looking at that top number. Because again, we have to realize the experience occurs not just at the time of the procedure, it occurs from the time that they first make an appointment to the time they come into the parking lot. All of those are components of what the patient experience is. But we're really building loyalty and trust. We are never going to be 100% perfect. But if that patient knows that we care about them and that we're doing our best and that everyone's engaged in their care, that occasional error is understood and the loyalty remains. But it's really important to provide not just the experience, but to build the patient loyalty and trust in you.
And that's not easy to do,
No.
especially when we're dealing with the vulnerable patient populations.
Absolutely.
That's part of our mission. And I think any tricks on that, so in your experience about, patients, especially our vulnerable patient population, there's a couple things that I've learned. One is they don't come to you, right? You have to go to them, right? So we're doing all our outreach programs. I call it an army of medical students that are working with me in the community. But if you could give us one tip on that your experience tells us.
Well, I think one of the things I would say is truly a component of patient experience that we don't always relate and call patient experience is health equity.
Yes.
We really have to be committed, and both Rowan and Virtua are very committed to health equity, to reaching that population with food insecurity or housing insecurity, minorities in difficult areas where they're unable to find care. I was at a conference last year and a doctor who started by saying he thought health equity was just political. Later then got to the point of talking about his own story of, he would have this patient come in and see him and was always dressed in Sunday best. He just thought that she didn't have any particular issues. And then during COVID, he did telehealth and saw the holes in the wall and the floor of the place where she was living.
Yes.
And realized that the assumption that this patient had the resources they needed, in reality, they may not be able to read the discharge instructions you're providing them. They may not be able to cook the food because they don't have an operable stove. So really understanding those social determinants and working ourselves as well as with our community partners on those issues will provide the best patient care.
Well, I think that is exactly what we're all about. It's about mission. I'm so happy to work with you and the work that we're doing together.
Yes.
And I want to thank you for being here today.
Absolutely. It
And
was a pleasure.
I just want to remind our viewers today to please keep listening to Dialogue with the Dean. You're going to hear great, as you heard today, guests that are really contributing to moving our mission forward. So I will see you next month. Thank you.